بسم الله الرحمن الرحيم.
The author carries no financial interest in this video. Video title: In Situ Bag Repositioning with Double Haptic Scleral Fixation of Multi-Piece Acrylic Foldable PCIOL. Purpose: to present in situ bag repositioning with double haptic scleral fixation of multi-piece acrylic foldable PCIOL. Setting: VOPHA Teaching Hospital Complex and Central Park Medical College, Lahore, Pakistan. Methods: a middle-aged male presented with subluxated capsular bag with multi-piece acrylic foldable PCIOL secondary to pseudoexfoliation syndrome. Pre-op visual acuity was counting fingers and improved to 6/18 with aphakic correction. In situ repositioning with double haptic scleral fixation of IOL was planned under local anesthesia. Partial thickness scleral tunnels was prepared at fixation site. Two paracentesis were performed. Anterior chamber was formed with injection methyl cellulose. Transscleral 10-0 proline fixation suture was passed 1 mm behind limbus. 27 gauge bent needle and 10-0 proline straight needles were used for this purpose, applying railroad technique, encasing the IOL haptic. Suture needle was retrieved at opposite limbal paracentesis using viscocannula as a guide. Suture was given a second pass. 10-0 proline needle coming through paracentesis while 27 gauge syringe needle entered through fixation suture site. Thus suture passage was repeated in opposite direction but anterior to the IOL haptic this time. Haptic bag complex was dialed in position at ciliary sulcus by applying gentle traction on the sutures. The fixation suture ends were tied to each other and cut ends buried inside the scleral tunnel. Anterior core vitrectomy was performed. Second fixation site was fashioned 180 degrees apart. Similar procedure was repeated with other pole of haptic bag complex. Haptic bag complex was dialed in position at ciliary sulcus by applying gentle traction on the sutures. The fixation suture ends were tied to each other and cut ends buried inside the scleral tunnel. Conjunctival flap was reapproximated at limbus. Suture knots were again rotated inside the corneal stroma. Wounds were hydrated. Results: the IOL bag complex was well centered at the end of the procedure and remained so to date, that is 3 months post-operatively. The BCVA is 6/9 with quiet eye. These are the post-operative slit lamp pictures. You can notice the well-centered lens bag complex and a quiet eye. Conclusion: in situ bag repositioning with double haptic scleral fixation of multi-piece acrylic foldable PCIOL is a viable and effective option for such cases. Using this technique, One does not need to retrieve the IOL or its haptics outside of the eye.